Thank you very much, Laura, for that introduction. Like Laura said, my name is Martin Celaya. Buenos dias, and I'm the Chief for the Office of Assessment and Evaluation within the Bureau of Women's and Children's Health at the Arizona Department of Health Services. And I'm very pleased to moderate this session on perinatal periods of risk approach in Arizona with my former colleague, Stephanie Brennhofer. As Laura said, PPOR is a comprehensive approach designed to help communities use data to reduce infant mortality. Designed for use in U.S. cities, U.S. metropolitan cities with high infant mortality rates, PPOR brings community stakeholders together to build a consensus and partnership based on local data. This is a very complex analysis that was developed during 2000-2004 by CityMatch, Public Health Department, CDC, and the March of Dimes. It was adapted by U.S. cities using an approach by the World Health Organization. Thankfully, our presenter, a previous ADHS epidemiologist, Stephanie, completed in 2020, and we are so excited to share it with you today. Though this is meant to be done by communities, we are stretching a little bit more to use PPOR to inform our state programs focused on maternal and infant health. It has given us tremendous insight into the particular populations and risks that mothers and infants in Arizona are experiencing. At this time, I'm excited to introduce you to Stephanie Brennhofer, who will share with you her analysis and findings. Then we will have plenty of time at the end for questions and discussions. So Stephanie Brennhofer is a senior data analyst in the Division of Infectious Diseases and International Health in the Department of Medicine at the University of Virginia. In her previous role, Stephanie was an epidemiologist within the Office of Assessment and Evaluation in the Bureau of Women and Children's Health at the Arizona Department of Health Services. Her concentration was on infant and child health, specifically infant mortality, where she was the epidemiologist on the Arizona Child Fatality Review team. Welcome, Stephanie.
Thank you for the introduction, Martin. In my presentation today, I'll be covering the perinatal periods of risk analysis that I conducted while I was a maternal and child health epidemiologist within the Bureau of Women and Children's Health. So a few objectives for today's presentation. I'll briefly cover the Arizona mortality rates, some background as to what a perinatal periods of risk analysis is and why we conducted it, the results of this analysis, and then the potential recommendations to reduce fetal infant deaths based on our findings. So throughout this presentation, you'll hear me refer to the following 5 race and ethnicity groups as presented on this slide. And this is the terminology that the Arizona Department of Health Services Bureau of Public Health Statistics uses when they publish their Arizona population health data on an annual basis. And since all data from this presentation comes from this bureau, I will follow their terminology. Right, so on to the Arizona mortality rates. So this figure depicts the infant mortality rate per 1,000 live births since 2009 in Arizona, which is the navy color, and then also the United States, which is the orange color. And for the most part, Arizona's infant mortality rate has remained below the national average during this period of time. So this figure is a deeper dive on the Arizona rates by race and ethnicity, where the overall state average is still navy, and then the other 5 colors represent the different races and ethnicities. An even deeper dive into the races and ethnicities, there's 2 groups that I really want to focus on and is going to be the main focus of this presentation. And that's American Indians and Alaska Natives, who are represented by the maroon line, and then Black and African Americans, who are represented by the yellow line. And when we compare them to white non-Hispanic infants, which is the orange line, we can see that their rates of infant mortality are much higher. So now that I have you thinking about mortality rates, let's discuss what a perinatal periods of risk analysis is and why we decided to perform this analysis. So despite the agency's best efforts, the infant mortality rate in communities of color in Arizona have remained high. And a previous perinatal periods of risk analysis was done by the agency over a decade ago, but it stopped at phase 1. And there are 2 phases to this analysis, where arguably the second phase is actually the most important because it gives us actionable items to reduce fetal infant deaths. So therefore, we decided to fully conduct this analysis and see it through because we needed to identify modifiable risk factors for our most impacted communities. So that's where this analysis came in. So what is a PQR analysis and what does it do? So it's essentially an analytic framework used to investigate fetal infant mortality. And this is usually conducted at a city or county level by a local health department. And it uses available information to help identify opportunity gaps or areas of opportunity amongst priority populations. And the outcome of this analysis is a short list of areas for us to focus targeted intervention efforts. And while this is generally conducted at the health department, the real goal of this analysis is to have community partnerships throughout this entire analysis and for the communities to really take ownership of the data and for the interventions to come from the communities in what they see is going to work best to help reduce fetal infant deaths among their communities. So this is what we call a periods of risk map, where every single fetal and infant death is going to be categorized into one of these 4 areas. So in the cases where a fetus or an infant weigh between 500 grams and less than 1,500 grams, this death would be categorized under maternal health and prematurity, if that was their birth weight. Now in the cases where the birth weight of the fetus or infant is 1,500 grams or more, they're classified into the period of risk based on their age of death. So for a fetus, it would be maternal care. In the neonatal period, it would be newborn care. And then in the post-neonatal age, it would be infant health. So each of these 4 periods of risks come with its own set of prevention and risk factors. And these are just some examples of what we tend to examine. This is by no means a comprehensive list, but for maternal health and prematurity, we tend to look at preconception health and if prenatal care was sought out and when, health behaviors and social determinants of health. For maternal care, we might want to investigate antenatal care and then high-risk referrals and obstetric care. For newborn care, perinatal management, neonatal care, or surgery. And then for infant health, we tend to look at the sleep environment, breastfeeding, and injury prevention. So the perinatal periods of risk approach is a 6-stage community-based assessment and planning approach to curb infant mortality. And so far, the agency has already completed steps 1 and 2. And I'll briefly cover what each step is to orientate you to this process. So in stage 1, that's really where we bring in community partners and stakeholders to discuss the PPOR approach. And that includes to having them commit to act on the results and to follow it through all 6 stages. In stage 2, there's 3 main components where we have the analytic preparation, so preparing our data, and then phases 1 and 2, where the fetal infant mortality data is actually analyzed. In step 3, we bring back our community stakeholders and partners to discuss the results uncovered from step 2, and then to detail a focused and data-driven public health plan or intervention to best reduce fetal infant mortality amongst our priority populations. In step 4, we're going to assess community readiness again, and then implement the program or the intervention within the community. And then in step 5, we're going to evaluate and monitor the program or intervention that's been placed within the community and to see if it's still addressing our goals and objectives that have been set forth by our community stakeholders and partners. And step 6 is the final step, but it's really meant to be long-term. So there's extra effort in this step to ensure that community stakeholders and partners still share the same vision for how we should approach reducing fetal infant deaths and really committing to a long-term investment to improve birth outcomes within the community and our state. So this presentation is going to focus on step 2, and I'll be going through the results. So going into this analysis, we do have some assumptions that I feel I should outline. We have to recognize that not all infant deaths are going to be preventable, but we can identify priority populations where excess infant deaths occur, and then identify areas that we should prioritize to reduce these excess deaths. So we'll start with phase 1. And in phase 1, we determine who we're going to include and exclude from the analysis, and every single death is categorized into one of our 4 periods of risk, which I have at the top as a reminder. And then within each period of risk, we calculate the mortality rates and the excess mortality rates. And then based on those calculations, we determine who our reference population is and who our priority populations are. And then the final part of the stage is to identify the period of risk with the highest excess mortality rate within our priority populations. And it's really this result from phase 1, which guides us into phase 2. So briefly, to be included in this analysis, the infant birth and death certificate needed to be from 2014 to 2018. So we only included infants who were both born and died within this period of time. And it's important to note that for a fetal death, there's only a fetal death certificate, which is issued. They don't also get a birth certificate. So the fetal death certificate also needed to be within that 5-year time period. And for a fetal death to be included, it needed to be at least 24 weeks gestation and 500 grams or more. And then for an infant death, they needed to be 500 grams, and then to be classified as an infant death versus a fetal death, these infants were born alive. In terms of exclusion, we did not include instances where the pregnancy was terminated or instances of spontaneous abortion. So after all of this, we ended up analyzing 3,092 fetal infant deaths from 2014 to 2018. So in general, the reference population is based off of the population who tends to have the best health outcomes. And I put best in quotes because it's important to remember that the reference group numbers and rates that I'm going to share with you are attainable because they have been attained by the group already, the reference group. So for some of the analyses, our priority populations will be compared against this group. So the reference population typically used for a perinatal periods of risk analysis are white, non-Hispanic Latino women who are ages 20 years and up and have more than a high school education. So for our analysis, we did change the age range to be from 20 to 35 years of age for the mom, as the literature does indicate that there can be poorer outcomes when the mother is over 35, and we did not want that to confound our analyses. So this figure outlines the 4 periods of risk labeled on the left, and within each period, you can see the number of expected infant deaths, which are in the gray bars, and then the number of excess deaths, which are represented by the colored bars. And we can see that in the maternal health and prematurity period, that's where we had the greatest number of excess deaths at 301. And our total number of excess fetal infant deaths of the 3,092 was 693. And when we actually do the math on that, we can see that 22% of these fetal infant deaths were preventable. So on the next 5 slides, I'm going to take you through the excess death numbers and the rates for our 5 race and ethnicity groups recognized by the Bureau of Public Health Statistics. So we'll start with American Indians and Alaskan Natives. where their excess death rate was 6 per 1,000 live births and fetal deaths. And of the 292 deaths, 150 of them were excess, which means that 51% of the deaths amongst American Indian and Alaska Native babies were in excess. When we look at Asian and Pacific Islanders, they actually have no excess deaths at all. The excess death rate for Black and African Americans is very similar to what we saw for American Indians and Alaska Natives, where they also had an excess mortality rate of 6 per 1,000 live births and fetal deaths. And of their 264 deaths, 135 were excess, which also comes out to an excess where 51% of the deaths were in excess of what would be expected. The excess death rate for Hispanic and Latinos was 1.1 per 1,000 live births and fetal deaths. And of the 1,156 deaths, 191 were in excess, and that comes out to about 15% of the deaths were in excess. And finally, for whites and non-Hispanics, their excess mortality rate was the same as Hispanics and Latinos, were 1.1 deaths per 1,000 live births and fetal deaths. And of the 1,286 deaths, 214 were in excess, which is also 17% of the deaths. So based on our excess death rates, we now know which periods of risk to focus on as a state and who our priority populations are. So our first priority population is American Indians and Alaska Natives. I didn't share this on the last slide as I didn't want to overwhelm you with a ton of data, but for our priority populations, I will share the mortality rates. So the overall mortality rate is actually 11.8 per 1,000 live births and fetal deaths, and their excess mortality rate was 6 deaths per 1,000 live births and fetal deaths. So when we look at the mortality rate map, which is the one on the left, we can see that the highest rate is actually in the maternal health and prematurity period of risk. Now, generally, for this analysis, we actually go off of the excess mortality rate map to determine which periods of risk to focus on. So in this case, it actually shifts to the infant health period. But we felt that it was important to still include maternal health and prematurity, given that it had the highest rates in the mortality rate map. Therefore, we decided to go forward with both. So for American Indians and Alaska Natives, this analysis will focus on the maternal health and prematurity period of risk, as well as infant health. Our other priority population are Blacks and African Americans, as there was an infant mortality rate was 11.7 per 1,000 live births and fetal deaths amongst this population, and their excess mortality rate was 6 deaths per 1,000 live births and fetal deaths. And as we can see from both of the maps here, it's very clear that the maternal health and prematurity period of risk is where further investigation is needed. So that was the end of phase 1, and now we move on to phase 2. And in this phase, we're going to investigate the periods of risk with the highest mortality, and then identify the probable causes for that excess mortality, what risk factors are contributing, and the potential impact that they may have. So since phase 1 revealed that we should focus on maternal health and prematurity for both American Indians and Alaska Natives and Black and African Americans, we will start there. So this is a flow chart specific to maternal health and prematurity to walk us through what these steps might look like. So we're currently in phase 2, step 1, where we need to determine if this is a birth weight distribution issue, meaning that we have too many babies who are born at a very low birth weight, or if this is a birth weight specific mortality issue, were a high percentage of our births under one of the 7 birth weight specific mortality groups, which indicates problems related to perinatal or medical care that's provided to the mother or infant before, during, or after delivery. So to determine if we have a birth weight distribution or birth weight specific mortality issue, we performed a Kitagawa analysis. And a Kitagawa analysis essentially mathematically splits the excess mortality rate into one of these two groups, birth weight distribution or birth weight specific mortality. And it does this by quantifying the differences in health outcomes between our priority populations and the reference group. So this analysis was performed separately for American Indians and Alaska Natives compared to our reference group, and separately for Black and African Americans compared to our reference group. So first, we compared American Indians and Alaska Natives to our reference group. And from this pie chart, you can see that 67% of the excess deaths were attributed to birth weight distribution, meaning that we have too many babies who are born at a very low birth weight within this population. So the goal here then is to get these babies to term, because what this is saying is that their survival rate is actually the same as the reference group once they're born, meaning that interventions after birth are actually not going to be what decreases this type of excess death, because this problem specifically relates to the social, health, and economic disparities of the mother that result in her delivering a very low birth weight baby. So given that 2/3 of our excess deaths fall into this category, that is what we pursued for the next stage in analyses. But I do want to note that 33% of excess deaths attributed to birth weight specific mortality is still concerning, even though it's a smaller percentage, because what this means is that the survival rate of American Indian and Alaska Native babies who are born at a very low birth weight are not as good as the survival rates of our reference group. So this problem does relate specifically to the perinatal and medical care provided to the mother and infant prior to, during, and after birth. So the next step in the Kitagawa analysis was to do the same comparison, but for Black and African Americans with the reference group. And from this blue circle on the screen, we can see that 100% of the excess deaths were attributed to a birth weight distribution issue. So this gives us a very clear guidance as to where we need to focus our efforts, as in we have too many babies who are born at a very low birth weight. And the key to stop this from happening is to get these babies to term, because the problem is not with the healthcare system or with healthcare personnel, but really problems that relate to the social, health, and economic disparities of the mother, which result in the delivery of a very low birth weight baby. So given the findings from the Kitagawa analysis that it's a birth weight distribution issue, we then move on to phase 2, step 2. And the items listed here is a very short list of different factors that we want to investigate for very low birth weight babies. So this slide is a more comprehensive list of the prevention and risk factors for the maternal health and prematurity period of risk, where on the left, we have the very low birth weight babies, where it's a birth weight distribution issue, which is where we're going to focus our efforts. But then on the right is what we would have focused on if it was a birth weight specific mortality issue. So the orange box on the left highlights the possible factors that we can look at, and the ones that are shaded orange are the ones that we did look into based on the data that was available to us. So to narrow down this list, we calculated population attributable risks and risk ratios, where the population attributable risk gives us the upper limit of benefit if we were to address that risk factor. But it's really important to keep in mind that this is the upper limit, as different risk factors influence and affect each other's This is sort of the maximum benefit that we could potentially see if this risk factor were addressed. So our short list of items to focus for American Indians and Alaska Natives are inadequate weight gain during pregnancy, not receiving any prenatal care during their pregnancy, having multiple gestations, and having previous preterm births. So while risk ratios are commonly found in the literature, population attributable risks tend to be harder to find, not that common. So I'll go over that interpretation, but I do have how you would interpret these numbers for either type of analysis. So if we look at prenatal care specifically, or not receiving prenatal care, so if American Indian and Alaska Native women who receive no prenatal care could have the same low risk as American Indian and Alaska Native women who do receive prenatal care, we could reduce very low birth weight babies by up to 13.9%. So we actually see the exact same shortlist for Black and African American women, where again, it's the inadequate weight gain, not receiving prenatal care, multiple gestations, and a previous preterm birth. So if once again, we were to look at no prenatal care, if Black and African American women who receive no prenatal care could have the same low risk as those who do receive the care, we could reduce very low birth weight babies up to 7.3%. And I use no prenatal care because I know that that's a topic special to many people, and I thought that that might be one of the risk factors that most people would be interested in, even though the risk ratios and population attributable risk percentages are higher amongst some of the other risk factors. So that concludes phase 2 maternal health and prematurity for both of our priority populations. And now we're going to move on to phase 2, specifically infant health for our American Indian and Alaska Native infants. That being, as a refresher, the infant health period of risk for American Indians and Alaska Natives actually had the highest excess mortality rate. So once again, we'll start with phase 2, step 1, where we need to determine where these excess deaths lie. And the 3 factors listed here are actually 3 of 6, which I'll cover in the next slide. So in this table, in our very first column, the causes of death, this lists the 6 causes that we typically examine in this period of risk. So congenital anomalies, infections, injuries, perinatal conditions, sudden unexpected infant deaths, and then there's another category. However, to be able to conduct this analysis, we need to have at least 20 deaths per cause for both our priority population and our reference group. And as you can see from this very blank table, this only happened for sudden unexpected infant deaths. Therefore, that was the only cause of death we could examine. And so that the numbers from the other 5 causes listed here were actually lumped together for analytic purposes. So once again, this period of risk has its own prevention and risk factors. All 6 causes of death are listed here and the potential factors that we would look at. The orange box indicates the ones for sudden unexpected infant deaths, and I've highlighted the few that we are able to look at. So the first table, the one listed at the top, is specific to American Indian and Alaska Native infants, where 1.42 deaths per 1,000 live births were sudden unexpected infant deaths, which is quite a bit higher than what we see for our reference population, and I have them listed at the bottom as a reference. So among our reference population, they only had 0.47 sudden unexpected infant deaths per 1,000 live births. And this final table at the bottom outlines our excess mortality, which indicates that 40% of the excess mortality in this period of risk was actually due to sleep-related causes. So next I'll focus on some possible recommendations to focus our efforts and recap what we reviewed. So American Indian and Alaska Native and African American and Black women had the same 4 risk factors to focus prevention efforts to reduce the number of babies who are born at a very low birth weight, which is inadequate weight gain, multiple gestation, previous preterm births, and not receiving any prenatal care during the pregnancy. And I do want to note that multiple gestations really are not preventable unless there's a lot of assisted reproductive technology going on. And although we cannot prevent a previous preterm birth, those aren't preventable. What we can do is moving forward for the mother, making sure that we're educating the mom about her risks for a future preterm birth and assuring that she receives the inter-pregnancy health care that she needs. So any existing health conditions she has can be addressed before her next pregnancy. And then also ensuring that she gets into prenatal care early. When we move down to the bottom half, focusing on infant health for American Indian and Alaska Natives, the focus here is really having babies in a safe sleeping environment, which could reduce the excess deaths in this period by 40%. So I would like to note the strengths and limitations of this study, or some of them. For the strengths of this study, this was a very comprehensive 5-year analysis of births and fetal infant deaths for Arizona using data provided by the Office of Vital Records, where all births and deaths could be linked, were included in this analysis. In fact, we were actually able to match 99.9% of death certificates with their corresponding birth certificate in instances where the infant was born and also died within Arizona, or their mother was a resident of Arizona on their birth, and the infant or fetus was considered a resident at the time of their death certificate, were included in this analysis over this 5-year period of time. And less than 5% of our data for any of the factors we looked at was missing, so we didn't need to impute any of the data. As for the limitations, we relied solely on birth and death certificates. So we're limited to the information that's available there. And it's just not possible to capture every single risk factor or preventive factor that would be necessary on these types of documents. And of note, the race classifications on birth and death certificates can be different. So on the birth certificate, it's actually the mother's race that's used for the child. Whereas on the death certificate, a combination of maternal and paternal inherited race is likely to be reported. And as you've seen throughout the presentation, the Bureau of Public Health Statistics only reports out on 5 races and ethnicities. So there's no 2 or more race or other category for people to select into. So we may not be accurately capturing the race of the fetus or the infant. And typically, we would have conducted this analysis at the county or city level, as that's what it was designed for, but there actually were not enough deaths for us to be able to conduct phase 1 and phase 2 fully in either one city or one county, which is actually a good thing if you think about it. And finally, we were unable to carry out phase 2, step 2 of the infant health period, as we were unlikely to have further information on the infant sleep environment. So our next step in the PQR cycle is strategies and planning. And that's where community stakeholders and partners are going to come back together and use the results uncovered in step 2 to detail a focused and data-driven public health plan or intervention to best reduce fetal and infant mortality within their communities. And finally, I would like to acknowledge the following individuals, as this work would not have been possible without them. Martin Celaya was my supervisor at ADHS within the Bureau of Women's and Children's Health. And he helped get this PQR process going and brought in the community. And then once we had buy-in, he brought in me to conduct the analysis with his guidance. I'd also like to thank Erin Ogram, who is an epidemiologist within the Bureau of Public Health Statistics. And she provided statistical support as she developed the code to actually help match our birth and death certificates. And then together, we went through every single match to make sure that it was accurate. And finally, to Carol Gilbert, who's a senior health data analyst at the University of Nebraska Medical Center, who provided us technical assistance throughout the entire analysis and helped us identify our prevention and risk factors and aided in the interpretation of our results.
Thank you so much, Stephanie, for that wonderful presentation. And it's nice that we're able to get everyone together to really share the findings of this really important analysis that hasn't been done in our state for quite some time. And again, thank you for getting on board with the project about a year ago when we were coming up with it, not knowing where it would take us. But of course, that's the purpose of why this summit was created, to share these findings with folks. And really, at the end, the story is, improving women's health will ultimately improve infant mortality in our state. And so Stephanie's analysis proves that. So we do have a few questions coming in. Some I'll go ahead and address really quickly, and I do have two on regarding methodology for you, Stephanie. So the first one here says, how can we help since most American Indian women are followed by IHS, and it is very hard, if not impossible, to reach them and provide services from Yuma County? I can only speak for the state here in saying that we do have some partnerships going on with our different tribal organizations, with the Intertribal Council of Arizona and with the Navajo Nation's Department of Health. Here at the state level, we're trying to do our utmost best to reaching out to communities to work on innovative approaches to improving maternal health. So I can speak to that approach. And then the other mention that I have here from Carol Gilbert is, it is interesting that the census classifies people who only have IHS as uninsured. And that's my understanding of that, Carol. It may be because IHS is considered a payer of birth from my perspective, but I'm not exactly sure if it's an insurance similar to Medicaid or Medicare. But I have been explained that distinction, but again, I am not with the Census Bureau, but that's my assumption there. Specific to Stephanie, a question that we have coming in is, what prevented the inability to analyze at the county or city level, from Sally?
Yeah, so the reason that we weren't able to conduct this analysis at the county or city level is because we didn't have enough fetal or infant deaths to see the analysis through from beginning to end. So to be able to make the claims that we've made, you need to have a set number of fetuses and infants who have died within each period of risk. And when it came down to it, even when we looked at Maricopa County, which is our largest county with the highest population, while we had enough deaths to do phase 1, we didn't have enough to do phase 2. And the recommendation is, for this type of analysis, if you can't complete all of it, if you can't do both phases, it's best to not do it at all. So that's why we ended up doing this at the state level. Good question, thank you.
Thank you. And so here, another one for you is, do we have the capability of differentiating human milk feeding versus formula feeding of infants who suffered sleep-related deaths from Olga?
So we do not have that information. So on the birth certificate, the only breastfeeding question that's there is if the mother was breastfeeding at discharge. So if you're only in the hospital for a day or 2 or maybe 3, that's really not an accurate representation for the type of milk that that infant was receiving up until the time of death. So that would be a great factor to look into. Unfortunately, we did not have access to that data.
And then one more question here with 7 minutes to go from Sarah Lee, and I think this might be one where we both address. I have seen some studies that showed African-American pregnant individuals who had lived in the US for many years had worse birth and maternal mortality outcomes than those who were newer to the US, refugee or other immigrant status. Is that something that you have been able to look at? Or is that something that a study in Arizona may look at in the future? I'm curious where specifically our families that are newer to the United States fall within the maternal infant mortality results. And with that information, how to best help if needed.
So that's a
Take
really
the first part and I'll take the second part.
sure. So that was a really interesting question, and we did not look into where the parents were born. So we do capture that information on the birth certificate, I believe, the country of origin of the mother. But that was not a risk factor that we looked at. That's very interesting information. I had not heard that those who were actually newer to the US had better health outcomes or better birth outcomes. In terms of analyzing that in Arizona, I think Martine will probably take this, but I do want to say that Black and African Americans does make up a rather small percentage of the Arizona population as a whole. So I think what it's really going to come down to is what are the numbers, and do we have a large enough sample size to truly look at those who were born in the US or have been here compared to those who have recently immigrated here. And Martine, I'll kick it to you.
Great. So I think you summarized that very well. I mean, refugee status or immigration status is not something that we have direct access to, right? This data analysis was using birth and death and fetal death data, and that type of information is not collected in those data systems. So, however, we do review every single infant and child death, infant and maternal death, excuse me. We do look at social risk factors such as potentially immigration status. That is dependent if the medical records show that information, right? Sometimes they may not. But again, going back to Stephanie's answer, the questions of numbers when it comes to epi analysis really comes into play, especially when we start to look at very specific communities. And so there's nothing to say that we couldn't look at, merging data, merging the years or looking throughout the different years and see what that would look like. But here we haven't necessarily done any of sort of that work just yet. We do know that we review all child and maternal deaths, and if that metric is captured, that characteristic, excuse me, it is recorded. But unfortunately, it's a question of numbers, like Stephanie cited earlier. Great. I think we are good with questions. Actually, you know what, Stephanie, I will ask one question that folks typically tend to ask. Why are mental health and substance use not represented in your findings when we know that that is a major issue for Arizona moms?
Yeah, that's a great question. And we do know that it's important. And it all comes down to what's available on the birth and death certificates. And neither of those items are captured. And since we limited this analysis to basing all of our findings off of those two documents, that's why we really weren't able to further explore this. However, I will say that we do publish a child fatality review report every single year, and we are able to tackle the substance abuse issue within that report, or if substance use or abuse played a role in the death of that infant or child. And that's because the child fatality review team actually has a statute in Arizona law that says that they must investigate every single death that happens within the state. And so they're able to get access to records that we weren't necessarily able to do for this analysis, because we are looking at slightly different populations in this analysis versus the child fatality review team. But we do outline that a little bit more in that report.
Great, thank you. And I think there is, I'm looking and see what the questions are coming in, but there is another question. Does any of the data include deaths due to mother addiction factors? And I think you just answered that question in terms of there's a serious lack of availability in some of these data sources, and the death certificate does not capture that. That is not to say that a further analysis could be done to see how we can connect those data points, but for this analysis specifically, that was not included. Great. Well, I think we are at time. We're at 2 minutes. There was a comment I do want to recognize. Oh, here we go. One more question. If we're comparing Arizona data to other states, are other states completing step 2 in the process? If so, it is then fair to compare Arizona data to other states.
Unfair in what regard? The overall infant mortality rates, or what?
I think they're asking about the PQR findings being comparable.
So the PQR rates and the findings are really specific to Arizona and our communities, and we could potentially argue that other states who have similar demographics might be able to benefit from the analysis that we conducted here. There are other city and county health departments who have conducted this analysis in other states. I know Ohio is one of them. So the literature is out there. A lot of it tends to get published in the Maternal Child Health Journal. So those are things to look for. I don't know that this has become as widespread as I think we would all like it to be, where this type of analysis is conducted. It is quite a large undertaking for both health departments and community and partner stakeholders. There's a lot of investment that goes into it. So I don't think we're really at a point where we can compare ourselves to other states based on these findings, because I think the point really is for us and our data and what we can do to better serve our communities.
Great, and we'll take one final question here with 30 seconds to go. What was the total number of birth certificates in the study again, and the year period length?
Yeah, so the study period was 2014 to 2018, and during that period of time, the infant had to be born and die within that period to be included. And then for fetuses, the death would have happened within that period of time, and the total number of deaths was 3,092.
Thank you, Stephanie. Wonderful to see you once again. And so for folks that are interested in getting downloading the slides from Stephanie, they are titled or named by her name. So Stephanie Brennhofer slides is the slide deck that you just seen. So next we're moving into a short break. We will be starting our next session called Access to Maternal and Infant Healthcare in Arizona at 10:40. So we'll see you soon back here. We'll see you back here soon.